You're audible, right, sir?
Now we are live.
Okay.
Wait.
Can I share the screen?
Wait. Sorry, yeah. Good evening. Good evening, all our respected members. So today we are having IAS Academic Corner monthly meeting. So we have moderators, Dr. Mahibul Islam, arthroscopy surgeon from Guwahati, and Dr. Dinesh Chidambaram from Coimbatore. And we have got three very good speakers, Dr. Sibin Sunendra, then Dr. Dinesh Dhaitadak, and Dr. Khayas Omar. So I'll just hand over proceedings to Dr. Mahibul Islam.
Thank you very much. Good evening, everyone. Welcome to the IAS Academic Corner December session. Hello.
Yes, you are audible.
Yeah, I'm audible. Na? Yeah. At first, I want to welcome everyone to this academic corner. The first speaker will be Dr. Sibin. He is Associate Professor from Government Medical College, Calicut. He will be presenting his talk on PCL reconstruction using PM and PL bottle. It should be a very interesting topic. So over to you, Dr. Sibin.
Yeah. So I'm just sharing that. Just let me know if it's visible. Is it visible?
Yes, yeah, it's visible. Yeah, it's visible.
Okay. Are we ready to go?
Yeah, sure.
So good evening to one and all. First of all, I'd like to thank the Indian Arthroscopy Society for giving me this wonderful opportunity. So my brief is to talk on PCL reconstruction using posteromedial and posterolateral portals. This is one of the way of doing PCL reconstruction and not the only way. So people are doing with only posteromedial portals or sometimes without posterior portals also. So I'm just presenting one of the ways to improve on the PCL reconstruction. So I bring greetings from the Department of Orthopedics, Calicut Medical College. So I should take you through the following steps. So that in between I will be discussing what is the posterolateral, how are we going to do with the posteromedial or posterolateral portal. To simplify for the beginners, I have divided into all the following 10 steps for the whole overall PCL reconstruction. So any arthroscopic surgery, as we are doing a keyhole surgery, you need to have the good understanding of the anatomy. So the PCL, as we all know, is composed of an anterolateral and an anteromedial bundle. And both the bundles are attached anterior to your medial intercondylar ridge. Just like the ACL, which is attached posterior to the medial intercondylar ridge, here the PCL is attached anterior to the intercondylar ridge, as you can see, and it is attaching just adjacent to the cartilage. So as you can see, the anterolateral bundle is much way bigger than the posteromedial bundle, and it is a major bundle that we usually commonly reconstruct. And if you can see on the opposite side, that's the tibial attachment. And if you compare with the PCL, the femoral attachment is twice as the tibial attachment. So usually that's why some of the people have come up with double bundle PCL on the femoral side to cover the large footprint, as you can see here. And as I told, it's everything on the femoral side is attached anterior to the medial intercondylar ridge, and specifically the anterolateral bundle is the most important one that attaches between the trochlear point and the middle arch point, that is around the roof of the knee. Coming to the tibial side, everything is attached on the PCL facet. The PCL facet is below the tibial plateau. Top part of the facet is the anterolateral bundle, and below is the posteromedial bundle. As you can see, the posteromedial bundle hugs the anterolateral bundle. Although the anterolateral bundle is the stronger one, on the attachment side, on the tibial side, it's the posteromedial bundle, which is lower than this. And the attachment is just adjacent to the ridge. This ridge is called as the champagne glass drop-off. And just at that point is the attachment site. How do you find out this attachment site arthroscopically? By looking for the popliteal fibers. The this ridge is just above the popliteal fibers. So this is something otherwise called as the champagne glass drop-off. Another thing that you should be important anatomical structure that you should be vigilant during posterior arthroscopy is the root of the medial meniscus, posterior root of the medial meniscus, just in the top part of it. So the PCL is between these two, between the popliteus and the root. So the same thing, the posterior attachment on the posterior side of the tibia is just adjacent to the popliteus. And this is a small video which shows the same anatomy, as you can see. So that's the ridge, and otherwise called as the champagne glass drop-off. And that's your posterior medial bundle, anterolateral bundle. and the PCL is hugged by the meniscofemoral fiber. So don't confuse it, those the meniscofemoral ligaments on anterior and posterior. As you can see in flexion, the anterolateral bundle that gets taut. So it's in flexion. PCL is mainly a flexion structure. So it tightens in flexion. After knowing the anatomy, go to the clinical findings. So in any arthroscopic case, whether it's knee or shoulder, it's a good habit to do an exam under anesthesia before you drape the patient, and always try to compare it with opposite side before you drape. So always position the patient yourself, start and compare with opposite side. And if you find that it's a grade 3 PCL, always think of something more than just being PCL. There may be collateral injury, there may be meniscal injury, something more than that. Make it a habit to mark the distal pulse. And if you have any doubt regarding the instability, take a CM view. So that will help you. Now, starting going to the setup, you can do either with the leg hanging or you can do with the leg on the table. The important armamentarium that you should have is always have a PCL jig of a good company, and have elevator and protecting scoops, and have some of the arthroscopic, shoulder arthroscopic instruments like the cannulas, Bissinger rod, and the radiofrequency ablator. If you have a 70-degree scope and arthroscopicum, it is well and good, but it's not a must. But other instruments are important for your PCL reconstruction. Coming to the portals, on the anterior side, you usually make 3 portals: a normal anterolateral or a high anterolateral, a low anterolateral, and a high anteromedial portal. So in case of, unlike in ACL where you make a low anteromedial portal, here you make a high anteromedial portal. Why? When you make a high anteromedial portal, you are able to reach posteriorly more deeper into the tibia. And on the posterior side, you make a posteromedial portal and a posterolateral portal. If you are only a person doing with a posteromedial, you can make a high and low posteromedial portal. How do you make the posteromedial portal? Keep the knee flexed around 90 degree, and the portal is made under the illumination from the arthroscopic illumination. It should be made above and behind the femoral condyle. It should not be at the level of the joint. It should be high and posterior. So then only you will be able to visualize the back of the tibia. So it should not be the joint line, high and posterior. You can keep a cannula, with or without cannula, you can do. Now going to the anatomy of the posteromedial and posterolateral portal, if you're making 2 portals, always start with mark the surface anatomy before you start the scoping. On the lateral side, you mark the lateral collateral ligament attaching between the epicondyles and the fibula head and the biceps femoris. So all your main structure, the common peroneal nerve, is always behind the biceps femoris. So all your portals should come in this triangle on the posterolateral side. And on the medial side, you mark the MCL and the hamstrings. So on the lateral side, you are between the LCL and the biceps femoris. That's the soft spot, and that's the important one. I will never come behind the biceps femoris. On the medial side, you come between the MCL and the semitendinosus, the hamstring tendon. So that's your soft spot. So if you are doing only with the posteromedial, you can make a high and low posteromedial portal. But what I commonly do is a posterolateral and a posteromedial portal. The main advantage of putting a posterolateral portal is that it's ergonomically easy. So when you can do all the work from starting on the lateral side. You need not turn your head. Suppose you are doing from the posteromedial side, you always turn your head back to see the screen if you have only a single screen. So ergonomically, that makes life better, easier. A little more detailed in the anatomy of the posterior portals. As you can see in this cross section, the posterior have a posterolateral compartment and a posteromedial compartment, which are separated by a posterior septum. This septum is connecting the neurovascular structures to the PCL. So there is nothing much in the septum except the fatty tissue, and on the top part you have the middle geniculate artery. So once you pierce the septum, you can communicate the posterolateral and posteromedial compartment. Now, as you see, the posterolateral compartment is a small compartment, so it acts as a viewing portal. And posteromedial is a large compartment, so that's your working portal. So that's the thing. And as I already told, the majority of the part of the septum is basically fatty tissue, except the upper half. Upper half, you may find the middle geniculate artery. So even if there is some bleeding, don't get worried. In the top part, it is usually the bleeding through the middle geniculate artery. Now, how do you approach the posteriorly? Now, what the commonly approach that I commonly use is the intercruciate approach, which has been published by Dr. Pancha in the article of the Journal of Isacos. So you start by looking through the anterolateral portal and going through the anteromedial. Here you need a RF. As you can see, this is the ACL and that's the PCL, stump of the PCL. And you start going between the 2 cruciates and go posteriorly. And how much will it go posteriorly? You can use shaver as well as the RF, and you go posteriorly till you reach the roof of the posterior edge of the roof of the bony roof of the intercondylar notch. And just behind it, you will find the posterior septum. As I told you, don't work in the upper half of the septum. Work on either side of the septum. That you will see the posteromedial, and you will make the open the posteromedial and posterolateral window. As you can see, once you open the posteromedial and posterolateral window, you can pass a Wisinger rod from the posteromedial to the posterolateral and make an inside-out portal. So that's how you make the intercruciate approach. Previously, we were using the other technique that's called as a reverse notch plasty. That means you go between the PCL and the medial femoral condyle to make the portal on the medial side, and similarly work on the ACL and the lateral condyle to make another portal on the side, and connect the two by passing a blind rod through the septum. So it's a relatively blind technique that's not commonly done. What we commonly do is an intercruciate approach. Then you do the diagnosis scopy. Majority of the times, unlike an ACL, where you can find an empty wall, lateral wall, the PCL side is always, the tissue will be there. So PCL, the only, the indicator may be a ACL pseudo-laxity, as you can see here. The PCL may be full, and it's usually a healing in continuity on the PCL side. So slopey ACL sign is a major sign. Now always look for other signs of the other injury, like if there is a drive-through sign, indicates a posterolateral injury or a posteromedial injury. What we commonly, there are various techniques of PCL reconstruction. What we commonly do is an arthroscopic transtibial single bundle MCL reconstruction, and I will be discussing the same thing. The advantage of using this posterolateral technique and posteromedial posterolateral technique is that you are able to retain the remnant ACL fibers, specifically if the remnant PCL fiber, specifically if you have a normal ACL. So then in that case, when there is a normal ACL and a part of the PCL is almost intact, it's better, you need to have better visualization. And this technique of PCL, posterolateral and posteromedial viewership helps in retaining the remnant PCL fibers, and that helps in better healing. And you can use graft of any choice of your. On the tibial side, you have to come down to the tibial tunnel, as I told, is located way down. It should be on the infralateral aspect of the tibial footprint. Why infralateral? Because the PCL goes from the medial condyle to the lateral. If you come on the inframedial side, they may be rubbing on the condyle. Patient may not be, and it's a non-anatomic reconstruction. And similarly, you want to come low down because you want to reconstruct, you want to retain the as much anterolateral fibers as possible. As I told previously in the anatomy, the anterolateral fibers are inserted in the higher part of the PCL facet. And another thing why you want to come low down is to reduce the killer turn effect. As you can see, if you are low down, you have the killer turn effect is less. And when you're using the tibial jig, the jig is usually, the angle is what we commonly keep the angle is around 55 to 60 degrees, so that you have a wide killer turn. Rather than a sharp acute angle, you avoid the acute angle by using a large angle. Now, how does the posterior surgery look like? So you are looking through the posterolateral portal and working through the posteromedial portal. So the cannula is in the posteromedial portal, the scope is in the posterolateral portal. Now you are removing the tissues on the posterior part. And as I told you, the main indicator, as you can see, the small tissue, this red tissue is the popliteal fibers. And once you see the popliteal fibers, that means you are on the correct spot, the spot where the attachment is in the champagne glass drop-off area. You bring the shaver from the anteromedial compartment, anteromedial portal, and see that's the stump of the remaining PCL. So bring out the jig, the tibial jig comes from the anteromedial. It should not come from the anterolateral, because if you are coming from the anterolateral, your the footprint will be on the more medially. You want footprint on the infralateral part of the tibial footprint. So always the jig comes from the anteromedial, high anteromedial portal. So unless you are high, you won't be able to reach so low in the tibia. That's why you need a high anteromedial portal. So you do the drilling under vision, visualize through the posterolateral compartment, remove the sharp edges on the tibia, so that reduces the graft abrasion. And so you can see the stump is retained. The anterolateral fibers are very well retained. And then you pass a ethibond to railroad your graft. So after this, the tibial tunnel, you can plug the tibial tunnel so to reduce the loss of the water, because otherwise there will be too much fluid loss. On the femoral side, as I previously told, the attachment is just adjacent to the cartilage. It's just behind the middle femoral cartilage, around 1 o'clock on the right and 11 o'clock position on the left hand side. So it's way high, not in the middle 2 to 3 o'clock. It's around 1 o'clock position. That's because we are reconstructing in a single bundle, we are reconstructing the anterolateral fibers. So you can reconstruct the femoral tunnel either by an inside-out technique or an outside-in technique. Inside-out technique, you need a low anterolateral portal. As you can see, inside-out means you drill from inside to out. Outside-in means you use a jig and drill from out to in. So if you are using an inside-out technique, you use a low anterolateral portal. keep the knee flexed, hyperflexed around 100 degrees, and give a posterior push on the tibia so that you have better area to drill the tunnel. The outside in technique, the advantage is that you reduce the critical angle. So on the tibia, you have got the killer turn, as you can see, that the killer turn. On the femur, you have the critical corner or the critical angle. So that angle gets reduced if you use the outside in technique. And if you want to make two tunnels or a double bundle PCL, it's better to use an outside in technique. So you see the trajectory of the two tunnels. If you are inside out, you are more vertical, whereas in outside in, you are more horizontal. So that reduces the critical angle on the femur. Now, how do you make the femur portal? First, you visualize through the anterolateral portal. You mark the attachment site. So it's around 1 o'clock position, as I told you, or 11 o'clock position. Then you change the scope to the anteromedial portal. The bead pin comes through the low anterolateral portal. And you can use the drill as the jig so that you don't scuff the cartilage. So with the drill so that you can calculate the correct position of the femoral footprint. How do you pass the graft? You can pass the graft either by two techniques. Either a transtibial technique, means the graft goes through the tibia, then comes to the femur. That's a commonly employed technique. Or a transportal technique. Transportal technique is commonly done in all inside techniques, where the graft passes through the portal and you are pulling the graft from inside from the knee joint to the tibia. What I commonly do is a transtibial technique. For that transtibial technique, you pass a Bissinger rod over the prepared graft. So that helps you to push the graft into the canal. So you can see the graft passing into the femoral tunnel. And once the graft you fix the graft, you can see that the slopey ACL is gone. So that's an indirect sign that the posterior sag has been reduced. You can fix the graft on either side by the graft technique of your choice. So basically, you need a secondary fixation. And on the tibia, we have learned that you need a secondary fixation on the tibia, but the current articles show that hybrid fixation is better. So the thing you have to keep in mind when you're fixing the graft is that you have to keep the knee in 70 to 80 degree knee flexion. Unlike ACL, where you keep it near extension, here you flex the knee because, as I told previously, you are reconstructing the anterolateral fibers, which are caught in flexion. And always try to maintain the anterior tibial step of 10 millimeter. Especially, this is very important if you have doing a combined ACL PCL case, where you can over-reduce the tibia. So as I told, the hybrid fixation is the one that is coming up more and more in the literature. Hybrid fixation says that unlike the tibia, where you are fixing a staple, the interferon screw on the posterior side and with a screw on the tibia, on the femur side also, along with the endo button, you can fix the tibia and on the aperture side with a screw, a small screw. So this reduces the graft elongation, reduces the graft abrasion on the edges. This is because, as I told you, this is the critical angle. You may damage the graft. So on either edge, there is an upper fixation on both the femur and the tibia, as well as an outer fixation. So it's a hybrid fixation that reduces the graft damage and graft elongation. And postoperatively, always make it a habit to check the pulses. Give a PCL brace if available, and start with the basic thing in the rehabilitation. You have to start with a prone knee flexion to reduce the posterior effect of the gravity. So this posterolateral and posteromedial triangulation is otherwise called as a posterior triangulation. The main advantages are that you have direct visualization of the septum. There is no blunt penetration of the septum. It's everything done under direct vision, and there are no blind spots. You can see whole of the posterior compartment, and it's very ergonomical. As you can see, you can do whole of the surgery standing on the same side and need not turn your head back to see the slope. And it's not only useful for the PCL surgery, but it's useful for other surgeries, like you want to do a arthroscopic PCL reconstruction. You can do a medial meniscus ramp repair. You can remove the loose bodies. You can do a complete synovectomy like PVNS, etc. So this is a basic technique that is not only useful for PCL, but for all other surgery. So it's good to learn this technique. So why do you see what are the causes of poor results of PCL reconstruction? The most commonly reason is the non-anatomic graft placement. So this posterior triangulation or posterior top portals help you to have a better anatomy, reproduce the better anatomy of the PCL. Try to avoid a thin graft, less than 9 millimeter. Avoid it. Chance of failure is high. And go for a proper graft fixation. As I told, hybrid fixation is coming up to reduce the graft elongation. Select your patients well. If there are associated injuries, try to correct those along with the PCL rather than only the PCL. And aim for a good rehabilitation. The poor rehabilitation will also lead to graft elongation. Thank you. Thank you for your patience here.
Thank you. It was a very nice presentation. Any question from the house? Yeah, can you hear me?
Yeah. I'm ready.
Yes.
Any question from the house?
Yes, I have one question.
Yeah, Sandeep.
Sir, so when so like knee TKR position or this one? I mean, I missed that part. So TKR position or leg hanging?
I commonly do with TKR position only, no leg hanging.
And do you ever use a Siam?
No, Siam is only a backup. I never use Siam. Means if needed, we can use it, but Siam is there in backup, but it's not a routine to use Siam. Specifically with these two portals, when you are seeing the footprint, there is not much use of Siam.
And how much time is spent additionally for taking that this portal, the posterolateral portal?
No, maximum additional are 10 minutes, not more than that. Maximum is 10 minutes.
Thank you.
And regarding the post-op protocol,
Yeah.
you have told about the PCL brace, but it's not very readily available in all part of the country. So
Yeah,
what are the options that you can use?
No, what other thing you can use is you can keep the normal ACL type brace with some support, some padding over the calf area.
Okay.
But all that is makeshift thing.
Yeah.
You understand? That's the jugaad thing. But the ideal thing is PCL. As you told, it's costly. And
it's costly and it's not available.
Yeah, it's a difficult thing. But what I know, what we sometimes do is that you use the ACL brace with some padding, padding over the calf area and try to keep it there.
Okay.
Any other suggestions, Sandeep? Anything? Is there any type of brace?
It was very good.
No, brace. Regarding the brace, anything? Because the PCL brace is a costly thing.
Okay.
Suggestion from your side? What you use there?
For PCL brace, so if patient is affording, then PCL jacket brace. I mean, if not, then as you mentioned, we put the padding in the where exactly it comes in the proximal tibia, posterior aspect of the proximal tibia. So which gives little push for the tibia. That's how I do it. Some companies, I think Indian companies, have started manufacturing that padding with so you can just stick it up or put it up in regular knee brace.
Okay.
Dr. Sibin?
Yeah, Cass.
What's the preferred for routine PCL reconstruction?
No, I didn't get you.
Graft.
Yeah. A graft. Yeah. So what I commonly use here is the usually I use the peroneus longus graft because that's what I get a thicker graft, more than 9 millimeter with sufficient length.
Invariably for all cases, first choice is peroneus longus.
Not all cases. But suppose there is a I will try if all other things are normal, I will use only hamstrings. But usually PCL is combined injury. So the hamstring goes for sometimes ACL or a collateral. Then other thing available is a peroneus longus only. We don't have the allograft solution. So if everything is normal, only PCL, it's only a grade 1 or grade 2 PCL. No collaterals, nothing, you can use hamstring. Because usually there will be some stump of the PCL. You can always augment it with this technique. You need not shave the whole PCL. That's the advantage of PCL. The PCL is rarely completely gone. Usually you will find some bundle intact. Unless it is a grade 3 where it is collaterals are gone and the PCL, nothing is much there. So in those cases, you need a thicker graft. So better option for us is peroneus longus.
Even Dr. Rajiv here.
Yes,
what is your preferred fixation over the femoral side?
So preferred fixation for what I'm using is a soft tissue graft. So I use an endo button, and recently we started using screw along with that. I don't have much long-term data to say that, but the article says that some of the articles say that it reduces the graft elongation and reduces the sag. I need to.
You're using in all the cases.
Screw.
Pardon?
You're using button plus screw in all the cases.
No, currently they means just started a few months back.
Okay.
And sir,
before that I was doing only on the femur side, it was only endo button, and on the tibial side you use screw as well as a backup staple or backup screw fixation. But now on the femur side also we started using a screw.
Can I ask a question?
Yeah.
Dr. Sibin, I could have asked it personally because we are from the same department for the benefit of the audience.
Yeah.
But I'm asking this for the benefit of the viewers now. So you told you will do the tibial fixation, tibial tunneling, everything first, and then plug the tunnel with this thing, plug. So my concern is when we are dissecting the posterior and when we are seeing the popliteus and all, the compartment is actually compromised. So you are doing the femoral tunneling, everything after doing the tibial tunneling. So if you plug it in the anteriorly, the fluid pressure is so much that it might seep into the calf. So my preference is if the capsule is compromised. So if you see the popliteus, technically it is compromised. My preference, what I was taught also is to do the femur first. That fluid or escape will be less because anti-gravity femoral tunnel escape is less. So and then do the tibia. But the negative of that is when you are fresh and your hands are good, do the tibia first because that is our heart in mouth situation.
The advantage of doing tibia here is that the tibia is the most difficult part for the whole field of surgery. So the whole of the field is clean. Once you drill the femur and the field gets little shaky, and we are doing not PCL in a fresh case. It's usually a elective case. So usually there is less chance of fluid seepage. Anyway, you always see for that. But and we are not using pump. So it's only a gravity.
No, I was asking. Yeah, I was asking whether you have had instance where there is a calf
usually
like fluid.
Never had, unless in an acute case only we had some issues. Otherwise, on all the chronic cases, usually it doesn't go because the pump. You should not be using pump. That is the only thing. So some people can pump, then it is lead to calf pressure.
Can I ask a question?
Yeah, definitely, sure.
Yeah. So while fixing on the tibial side, how do you measure the length of the screw that you are going to use, and do you visualize it from the posterior medial portal while putting just to avoid injury to the neurovascular structures?
Yeah. It's a good question, nice question. So I usually visualize from the posterior and usually put the longest screw possible, usually 30 or 35 and 10 or 11 size screw. So put the guide wire, visualize it under the screw from the posterolateral portal itself. Guide wire comes in and then put the screw. So it's under visualization, it's an upper stud fixation usually.
And what length do you prefer for PCL?
Around
double
30,
peroneus.
The length of the graft, you mean?
Yes.
Graft should be minimum 10 to 11. Okay.
Yeah.
That's why you double the PC, double the peroneus, and you can add an additional hamstring also if the diameter is not good. So that gives a good length as well as a good diameter.
Yes.
Yeah, I think all the doubts are clear. Yeah. So thank you, Dr. Steven. It was a nice presentation. Yeah. Can we proceed to the next talk? Yeah. Dr. Khayas? Yeah.
Yes.
Yeah. Is your presentation ready, Dr. Khayas? Hello.
He's muted, sir.
Dr. Khayas?
Hi, Dr. Khayas. So I think we can ask Dr. Dinesh.
Yes, sir.
Yeah. Dr. Dinesh?
Yes.
Is your presentation ready?
Yes, sir. My presentation is ready, sir.
Yeah. Please share the screen.
Yeah, sure. Just a
minute. Yeah. So.
I think Khayas is online now.
Yeah. Can you hear me, sir?
Yes.
Yeah. Is your presentation ready?
Okay. Yeah, everything is ready, sir.
Everything is ready, no? Okay. Now the next presentation is by Dr. Khayas. Arthroscopic PCL double bundle button bony avulsion repair, no? Yeah. Dr. Khayas is an arthroscopic surgeon. He is assistant professor in Government Medical College, Calicut. So over to you, Dr. Khayas.
Yeah. Is my screen visible, sir?
Yeah.
Okay, sir. Okay. So, good evening, everyone. Thank you, Dr. Sandeep, for giving me this opportunity. And thank you, IAS, for having me in this session. And I'm going to talk about arthroscopic PCL double button avulsion repair. So PCL avulsion is the mechanism of injury is usually a direct blow to the tibia with the knee inflection, or it can be a hyperextension injury. So Mayer and McKee were classified into type 1, 2, and 3. Type 1 usually we conserve. Type 2, it can be conserved or it can be handled with surgery. Type 3, usually we go for surgery because it is fully displaced. And 2 or 3, the acute PCL avulsion, if it's a large fragment, you can go for either an open reduction and internal fixation using a screw, or you can go for an arthroscopic double button or a suture pull down fixation. That is the usual dictum. But the problem with the suture pull down fixation is that if you don't use the regular technique of the knot, the pulling will be and the PCL and the fragment will come up. So that is one problem. So it's better to do that newer technique of knot, which reduces the fragment. Otherwise, the technique which I am going to describe, the suture pull down fixation, instead of that, you can use that arthroscopic double button fixation. And if it's a small fragment, if the translation is less than 10, just you can go with the rehab. If the translation is more than 10 millimeter, actually, the PCL reconstruction is described because the fragment is too small for a bone-to-bone healing. So this is a case of a 21-year-old male and history of RTA and right knee injury. So hope my presentation is working all right, sir?
Yes.
Yeah, working.
Yeah. Okay. Some network issue came in. I don't know. So this is a type 2 tibial spine avulsion, the PCL avulsion. So this is the fragment in CT. It's almost 1.26 into 1.52 centimeter fragment. So it's quite big fragment, and there is an undisplaced or minimal displaced Schatzker fracture also in this case. So MRI showed no other ligament or meniscal injury, and this is the pre-op video. You can see a grade PCL positive. So fix or not. So my rationale for fixing was in type 2 PCL avulsion was the posterior grade 3, this thing is there, drawer, and minimally displaced tibial condyle fracture is also there. So anyway, operation surgery is needed for him, and he is a young active male willing to play football. Whether to do open or scopy. So open fixation, the Buck-Schaffer approach you can do. You can move the gastrocnemius and all, but it's a very morbid procedure, and you can see the fragment like this. This one, another case, not this case. So you can feel the fragment and put a screw. So open screw fixation versus scopy, the higher morbidity is there for compared to the scopy, and potential for neurovascular complications are there, and delayed rehabilitation in open. And if arthroscopic, whether to go for a double button fixation or a suture pull down. So as I already said, a suture pull down is not always really satisfying because of the reduction is not always in our hands, because we are taking bites in the suture, the PCL, and the fragment control is less. I myself had experiences where the fragment will jut out and the PCL is pulled down and the fragment will jut out. So we have to be more, technically it's more demanding. So if the size of the fragment is big, we can go for this double button fixation also. And according to the displacement of the fragment, the comminution, if it is comminuted, it's a big no, the double button fixation. Better to go for a suture pull down, and chronicity of the lesion. All these are important. This patient is planned for was planned for an arthroscopic double button fixation. So this is the PCL anatomy, as Dr. Sibin said. This is the posteromedial bundle, and this is the anterolateral bundle. So anteriorly, we are reconstructing more of an anterolateral bundle, but posteriorly, we will be usually fixing, reconstructing. When we are doing reconstruction, we'll be in between the posteromedial bundle and the anterolateral bundle. But here, it's a PCL avulsion. So the PCL is actually like a ribbon, a broad band of tissue in while viewing from the posterior in the normal. So the fragment will be seen and it will be just attached by a ribbon-like structure. So we have to be very careful about the gross anatomy of this structure. So now we are going for the video demonstration of this procedure. Hope I am visible and audible. Sandeep sir? Yes, okay. So this is the right knee and 90-degree flexion on table, TKR position, tourniquet applied, no pump. High anterolateral and high anteromedial portals were used. Then the posteromedial, accessory posteromedial and posterolateral portals were used. So here I usually, this is a case done 4 years before. So I usually used to do viewing through the posteromedial portal. And posterolateral was just for clearing the septum and the transeptal to clear the posterior compartment. So in this video, you will see the posteromedial viewing portal and a posterolateral working portal and accessory portal just for this case to shuttle the suture and the button. And diagnostic round is also done. Nowadays, I use the posterolateral viewing portal, but I haven't done a case of tibial spine, the PCL avulsion through the posterolateral viewing portal. So diagnostic round shows no other injuries. So we are going for the lax in that ACL can be seen, and the PCL is normal on probing. That is usual picture we see in every PCL case. It will be normal usually. So two windows are developed. The first window is lateral to PCL, that is the in between PCL and ACL, and one is medial to the PCL in between the condyle and the PCL. So this is the creating window between PCL and the condyle, and I'm viewing through the anterolateral portal, and I'm going through this window between PCL and the medial condyle to see this is the posteromedial compartment, and I'm putting a stab incision and entering the Wissinger rod. Dr. Sibin has made the setting very clear for everybody to understand. So I'm not going to the details of the creating the portals. So this now I'm viewing from anterolateral portal, and the RF is coming from the posteromedial portal, and the septum is cleared. Make sure the septum is not cleared superiorly above the intercondyle notch because there is a artery risk. So always be down at the level of the joint, tibial joint. So now the RF is coming from the posteromedial portal. The septum is cleared. Now I am using the window between the ACL and PCL also for a better view of the septum. So these windows can be both used, and the jig always should be through the window between ACL and PCL. Then only you will get, if you're coming from the anteromedial portal, the jig should be through, ideally should be through the window in between these two. Then you will get the correct position behind. So that window is also cleared. Now the Wissinger rod comes from the posteromedial window, and I put a candle in the posteromedial window, and the Wissinger rod is coming from the posteromedial window, and it is transferred to the posterolateral window, and we make a posterolateral window. So this is the Wissinger rod is going there, and the posterolateral window is created, and we put an artery from the posterolateral window and dilate it, and now we have both portals. Now this is the artery coming from the posterolateral window. Now I am switching to the viewing from the posteromedial window and working through the posterolateral window. So that will be the picture now. So now the RF is coming from the posterolateral window, and I am clearing the posterior structures because in PCL avulsion, the tissue, the synovium, everything will be more less. It will be more difficult to debride compared to the PCL reconstruction. So I use both the portals for clearing it in a better way. So posterolateral, this is the fragment, the big fragment. Now I am switching to the posteromedial viewing, accessory posteromedial working portal for a focused view of the fragment and clearing the fracture bed. So this is, we are clearing the fracture bed. This fragment, you can see it is elevated from the bed. Fracture ends are freshened. Now I am working from the accessory posteromedial portal, and the fracture ends are cleared. You can see the tibial articular surface because the fragment is now totally up. When the synovium, everything is clear. You can see the poplitus, the shadow of the poplitus. Now the posterior compartment is also cleared. Now the jig is coming from through the window between ACL and PCL, and it is now we are trying to reduce the fragment. Now the reduction is then almost the jig is now 2 centimeters down. So we know that it is reduced, and you can see, you can feel that reduction when we keep the jig. So now we are going to drill through the fragment. This is after reduction, and after drilling, the endo button, this thing will come through this. The guide wire will come through the fragment, and make sure this is the next is the endo button reamer. So this is the moment of truth. So you have to be very careful that this is sufficiently far away from the margin. Otherwise, the fragment will get comminuted. And this is a 1.5 centimeter fragment. So I know that 4 mm drill bit will be sufficiently coming out. And make sure that this is going to be safe. The dead center of the fragment should be captured. And now we are going to drill with a 4 mm endo button reamer. And this is the moment of truth situation in this case. We are protecting the posterior structures with the jig, or you can use VCL, this thing, elevator. Now the endo-button reamer is out through the fragment. If this artery is to give counter to the fragment, and now you can shuttle with a proline through the endo-button reamer. And now this proline is taken through the accessory anteromedial portal, posteromedial portal for shuttling the tightrope. And this is already taken to the posteromedial portal, and this is all again dilated once more because of we have to pass the button through this accessory posteromedial portal. That rod is to dilate this. Now we have to prepare the endo button with sufficient length in the loop so that this loop can be used passed from the anteromedial surface of the tibia through the fragment to the accessory posteromedial portal, and we have to put a button on it and retrieve it. So this loop should be sufficiently long, and we are passing from anterior to post this thing. From this side, this will be the leading end. Now the suture is the proline suture is shuttled with the tightrope. You can see the fiber wire. Now we are going to this button is going to come from the posteromedial portal. So this button is taken, and it's an open button. So we can pass the thread over the gutters in the button, and it's a 11 millimeter disc. And this is passed through the posteromedial accessory portal using a artery or some grasper, and it is going to be placed over the fragment through the accessory posteromedial portal. Now it is over the fragment. It's over the fragment. And now we are going to tighten the structure. So the button is over the fragment, and it is kept nicely on the fragment through the soft tissue. And now we are singeing. So singeing is from the anterior. The endo button, the button will be getting flush with the tibial anterior surface. And now you can see the steps. We are singeing it from anteriorly. You can see in the screen the posterior viewing, and you can adjust the tension according to the feeling and the visible pictures in the screen. And the reduction is according to our tension, what we give in the, so endo button is anteriorly, and tibial condyle percutaneous screw also was applied. A standard post-op rehab protocol was done. Passive ROM and static quadriceps started after first dressing. I usually use the PCL rehab itself for avulsion also, but you can be more aggressive in avulsion. Partial weight bearing with crutches and brace after 3 weeks. Dynamic resistive exercise done. And this is the immediate post-op in 2019 October X-ray. This is the fragment sitting over the button sitting over the fragment. And this is 2 months later in November, and this is 3 years later in 2022 March. This is the fragment is still sitting beautifully reduced over the, and the button is still sitting over it. And you can see the post-op, 3 years post-op of this patient. There's no sag, and the scars are healed beautifully. So arthroscopic double button fixation is a feasible option for PCL avulsion fractures. It has the advantage of stable construct where the surgeon has complete control over the final compression, and no knots are involved, so no worry of loss of tension while tying the knot as in a suture pull down. And case selection is paramount for successful outcome. Thank you.
Very nice presentation, Dr. Kayas. Any question from the participant?
Dr.
Kayas, can I ask one question?
Yes.
Yeah, Kayas, nice presentation and good technique. My only worry is that how close to the trauma you do this. Is there a chance of fluid leakage? Because in this case, you had a tibial condyle fracture as well as a PCL avulsion. So what was done initially?
Yeah, this case.
How many days?
No, this case was just immobilized with a knee brace, and it was done 2 weeks later. 2 weeks later.
Okay.
No hurry in this. Because after, if it's done after 3 or 4 weeks, and it will be difficult for the reduction, everything will be messy behind. The 2 weeks is ideal for this case. No, this case was done 2 weeks later.
Okay. Because the earlier you do, better the easy to get the reduction. But the only downside is that chance of capsular leakage is there. Okay.
Anyway, if there is a grade 3 PCL drawer, definitely posterior structures which also be damaged. So better to let the joint settle a little bit.
Okay. And the main requirement is you should have a sufficiently large piece. If it is comminuted, what is your choice? Suppose it is a comminuted 2 or 3 piece, what is your choice of treatment? How do you go?
Suture pull down is the only choice. Suture pull down. Take bite with a lasso and tie it anteriorly. Okay. And the literature says if it's small fragments, better to go for PCL reconstruction or augmentation, because the healing, the bone-to-bone healing, you will never get. If it's a big piece like this, you can even go for a double button. But when we use the suture pull down in a big piece, the reduction, I don't know whether the house, what's your opinion? Because the reduction of the fragment is not absolutely in our control. If you have that Dinsha's technique, take a knot and place the knot over the fragment, then only that reduction will be there. If you take bites in the PCL and tie it, that fragment will jut out. My experience, I had 2 or 3 cases of that experience. So PCL avulsion, what's the opinion of the house? Whether use the knot to reduce the fragment, big fragment, or you accept the reduction. The type 2 like reduction. It will be touching, but it will not be reduced. It will be like just little bit. Any experience from the house?
It's a good technique. Hello.
Yeah.
It's a good technique. The pull out, if we do pull out and go more inferiorly, then the problem of jetting out is negated. But if you pull out suture, bring it from the anterior aspect of the avulse fragment,
I think there is some loss of connectivity.
Okay. Any other question or any other comment from the house?
Sandeep was saying that when you are using a pull-out technique, your tunnel should be just below that. Then only you will have the correct depth. Yeah. Otherwise, in this technique, you can come through the tunnel, through the base of the crater. Whereas other thing in the lower half of the crater, then only it will sit properly. Otherwise, the chance of...
And you have to take the bite, and you have to take the bite sufficiently lower.
Yeah.
If the bite in the PCL is higher, then it will pull the fragment. The fragment will go up, and the PCL will come down. So take sufficiently low bites. But when the PCL is flying, it's very difficult to control and take bites where we are actually willing for. So it's a little bit learning curve is there for that technique. Perfect bites.
So if there are no questions, can we go to the next talk?
Yeah, Dr. Dinesh is the next speaker. He is assistant professor working in Aurangabad and an arthroscopic surgeon. He is going to present ACL reconstruction with open physis. Yes. So over to you, Dr. Dinesh.
Yes, sir. I'll start my screen, sharing my screen, sir.
Yeah.
So is my skin visible to all?
Yeah, it's visible.
Okay. So thank you, Indian Arthroscopy Society and Dr. Sandeep sir for giving me this opportunity. So my topic today is ACL reconstruction in an open epiphyseal patient. Well, the incidence of ACL injuries in pediatric population recently has gone up, maybe because of more inclusion towards ground sports and young children. Also because of more awareness among children and coaches, and overzealous use of MRI studies. Also overuse of YouTube and Google by parents and children. Not that we didn't know about it, but we have come a long way in knowing about them recently. So what does the literature tells us? Well, this is a study by McConaughey et al. In 2011, where they did a arthroscopic findings in 70 children, and in which they found that almost 45% of adolescents had ACL tears associated with meniscal injuries. Another study by Henry et al., which shows where they did a retrospective study in almost 56 patients, where a group 1 patient were treated by ACL reconstruction, and group 2 were treated by ACL reconstruction after they have achieved their skeletal maturity. So what they found was that patients in group 2 had a higher rate of meniscal injury and higher rate of meniscus ACL tear and meniscectomy as compared to the first group. So what are the risks associated with ACL reconstruction in open epiphysis? As we all know that the distal femur epiphysis and the proximal tibial epiphysis contributes to almost 65 to 70% of total lower extremity growth. So the most common injury that we encounter is a leg length discrepancy and angular deformity because of potential injury to the physis while drilling either on the tibial or the femoral side. This is one of a study where they did a review of 4 cases in skeletally immature patients. And what they found was that 2 patients developed tibial recurvatum and 2 developed genu valgus. So which technique which technique should we use? But it depends actually on the skeletal age of the patient. If the age if the patient is having more than 2 years of physial growth remaining, then we should go for a physial sparing ACL reconstruction. If the age is around 2 years of growth remaining, then we can go for a partial transphysial, like using a transphysial tunnel in TB and trying to spare the physis in femur. Or if there is the age is less than 2 years of physial growth remaining, then we have to completely go for a transphysial ACL reconstruction. These are some of the techniques. So the first one technique is the physial sparing, where we have to spare both the tibial as well as the femoral physis. Second is a partial transphysial, in which the femoral physis has to be spared while we can go lenient on the tibial side. On the third type is the transphysial, where we transact both the tibial as well as femoral physis. And extra physial, in which the ITB band was used previously for rerouting. It was an rerouting for the ACL reconstruction. So here is my case. He's a 15 years old male. He had a twisting knee injury 2 months back while playing football. He came to us with a complaint of pain on walking and feeling of giving away of the knee. Initially, he was managed conservatively by local doctor, but after examination, we found out that he had a grade 2 Lachman, a grade 2 anterior drawer, and pivot shift test positive. So I'll start with the MRI and surgical procedure through it. Just let me know if you have any questions during it. So this is the MRI and his X-ray. That's his clinical examination under anesthesia. So here we mark the femoral epiphysis under Siam. That's the torn ACL identified from the anterolateral portal. And then we look for associated meniscal injuries on medial and lateral side. And after this, we debrided the footprint, trying to save as much of the ACL possible. Here you can see under CM guidance, I'm passing the bit pin across the femoral epiphysis, across the femoral condyle, trying not to cross the epiphysis. It was done on under CM guidance. That's the tibial femoral tunnel drilled. And that's the final graph. That's the stability. So in this case, we harvested a semi-tendinous graft and it was quadrupled. The aim of the ideal diameter that we were looking was 7 mm, and length was 65 mm. Since I was using a fixed loop, and the femoral tunnel which I got was 35 mm, so I used a 15 mm fixed loop, which gives me a 20 mm graft in femur, 20 mm in intra-articular, and 25 in the tibial. I used a cortical fixation on the tibial side with a suture disc. Post-op protocol is pretty much the same that we do for adult. Knee ROM was initiated the next day, and patient was made weight-bearing, walking with long knee brace. So the main dilemma is which procedure to it should be considered safe. Well, this study by Cohen et al. Has shown that transphysial ACL reconstruction technique results in a good clinical outcomes and has no growth abnormalities, where they have performed this research on 26 patients. Another technique by Pennock et al. Shows almost similar results with higher rate of return to sport and low rate of physical abnormalities. So in summary, with the increasing number of participation at early age in sport, number of ACL tear has grown up in last decade. So early diagnosis and early intervention in such cases has to be done rather than waiting till the skeletal maturity. We should try to spare the epiphysis as much as possible. And although we can try our level best, we have to inform the patient's relative, the parents and patient. We have to be they have to be consulted that going on further in their life, they might develop some complications in their deformities. This is one of the research article I found in Journal of Children's Orthopedics, where they mentioned that there are many gaps in treatment of pediatric ACLs, and though the current literature is still lacking in high quality research. So yeah, growth disturbance is still underreported, but we have to go for ACL reconstruction to prevent the further damage to the knee. So this is the treatment protocol that I think I follow most of it this time. Complete ACL tears in skeletal mature patient. If it is a male less than 12 years or a female less than 12 years, if the rehabilitation is not working, then a fascial sparing ACL with or without ITB in a male adolescent with growth remaining, like in our case where the age is 13 to 15 in males and 12 to 15 in females. A transfacial or a partially transfacial ACL reconstruction with hamstrings can be done. Thank you.
Thank you, Dr. Dinesh. Very nice presentation. Any question from the house?
Can I ask a question?
Yes, sir.
Dr. Dinesh, so we are always concerned about the transfacial technique, the transfacial injury in the femoral side more than the tibia, because tibia we can do it in the middle and less than the injury. So in drop, is there any technique so that the way you drill the tunnel, is there any tips you can give us to, okay, you told CM you have to use, but
yes.
Is there any tricks? Yeah.
For the femur?
To prevent the physis. Femur.
Yeah. So what I did was I have before the starting the surgery, I have marked the epiphysis on both AP and lateral views on CM. And what I was aiming was to get my bit pin to exit exactly at the same point, just below the epiphysis.
But the markings are on the skin, right?
Yeah.
So the skin and the bone, there's a distance. So the exact exit point of the beat pin in the skin may not be correlated with the exit point in the bone.
So
how can you?
That's why you have to use CM during the surgery. So to have the better exact point to for the tibia femoral tunnel.
So you have to do AP view and lateral view, right?
Lateral view, both. First, you can use an entry owl just to make sure that what you are drilling is in the right AP and lateral direction. Then you can go ahead by hyperflexing and putting your big pin.
You do it in hyperflexion, angle it little bit more medial,
Yes,
something like that.
you can use an accessory anteromedial portal as well.
Yeah, okay, a distant angle,
Yes,
yeah, away from the petal tendon, right?
Yes, yes, yes.
And do you check the inside the tunnel whether the physis is there or not?
No,
I've
that's
seen
very,
videos like
that's very difficult to see from the arthroscopy.
yeah, once drilled, it is done. The damage is done.
Because you have very little chance of passing big pin, like once or twice just can do it.
You can see a white line if the physis is reached.
Okay.
Can you use a outside in jig, like for all inside, no?
Yes, yes.
On the
yes.
femur side. So
Yes,
that will
sir,
give
yes,
more
sir.
control over the trajectory.
Yes, sir. I was thinking about it. After I've done the case, I was thinking that I could have used outside in drill. Yes, but that would have been very easy.
Yeah. So yeah, there is no much risk of otherwise controlling from the inside out is not that easy.
Yes.
You
yes.
have to take multiple C-arm shots. Still, you are not very sure.
Yes, that's true, sir.
Do you take always radiology, or it's always a chronological age you take, like 15 to 16 years, or you always correlate it
No,
with
sir.
radiology?
In this case, I had X-rays of his opposite limb as well as other joints, just to make sure that what I am doing is right and not like I'm not just using his chronology age. I'm using skeletal maturity age.
Okay. Is there a possibility, suppose it's a little younger age, is there a possibility that there is tether on the tibial side? Do you need to remove that implant on the tibial side on growth? Will it tether the growth on the tibial side?
Looking at his age, I don't think so. He's just 2 years from his maturity.
Yeah.
So
Suppose he was a little younger age group on the lower side, 10 to 12 years.
In that case, I would have used a CC screw or a cortical fixation on the tibial side.
Okay, and you can remove it later, huh?
Yes, sir.
That's what I was asking. Yeah.
Yes, sir.
Okay. Yeah. One of the tips I heard from one of the talks is that regarding the skeletal age, you take the X-ray of the hand. Understand?
Yes, sir.
And if
I've done that.
Yeah, the distal physis is fused. That means it's not fused. That means prepubescent. So that's very lower off. So you have to do a physial sparing in those cases. If the distal physis of the finger is fused, P3 is fused. That means it's pubescent, or so you can go for a little more toward the transphysial side. So just for a tip.
Dr. Sandeep, how often do you do pediatric ACLs in Bombay and Pune and all, in Maharashtra?
Well, how often? It's like it is not that often, but if that is the case, if I'm doing, so it is very simple. I use CM, the femoral tunneling with the inside out, all inside, and tibia. I put fixation, suspensory fixation for tibia as well. That's what I plan.
Use both the hamstrings or one hamstring? What is the common graft for the pediatric
Yes.
aging?
So the last one which I did was a 12-year boy, very obese. So for him, I took CQT.
Okay.
Using that Rajiv's technique I did. And I got almost 8 millimeter diameter graft.
One question that I wanted to ask is, in such pediatric population, how much diameter of graft do you aim for? Like, how much should be the ideal diameter?
I feel at least 7 to 8 has to be there.
Yeah, depending on the build of the child, with a very obese and large, it's better to go on the little higher side.
Yes, because once unlike bones, the graft is not going to gain further diameter. Whatever diameter you're going to put is going to last his life. So, but certainly not less than 7.
In our experience, what we usually say is the younger the child is, usually it goes for tibial spine avulsion rather than an ACL. So as the child grows older, like 11 to 12, then we usually say the ACLs in. So
No, so
the
correct.
growth is
That's
almost.
correct. But the
So
patients, football player and all.
9-year, 8-year-old.
Very.
We get
So far,
less
I
of the
have had
pediatric
About
injuries.
the
No?
tethering.
so correct.
Yeah, we in our population it's very less.
The one
The 9-year-old, 8-year-old coming with ACL.
yes, the youngest I had operated is around 10 years old. He had a avulsion, ACL avulsion.
Okay.
The other one which I
Avulsions are
mentioned
common.
for the 12-year-old. So that
Substance
was
tear, yeah, substance tear is pretty rare.
One question I wanted to ask: if this patient suppose had presented you within 2 weeks, would you have gone for a ACL repair in this case? Primary ACL repair?
I don't have experience with ACL repair, so I will not be the appropriate person, the right person to because I still think because so far I have not had opportunity or I have not yet tried ACL repair, primary ACL repairs. Dr. Sibin must have had some experience. Sibin sir?
Yeah, we just tried 2 cases, not in a pediatric age group, but in adults when there is a femoral avulsion, something like that, femoral peel off. But I think in the pediatrics, it's I think worth trying. If it is a classical femoral peel of type 1 type, then you can try it. I don't have experience in pediatric age group. Adults, 1 or 2 cases I have done, and they are doing good. But it should be you should
Yeah,
get the
compared to
correct patient and within 2 weeks, 2 to 3 weeks,
Yes.
and typical peel off. And but our patients usually come out later on. They do.
yeah, the literature says compared to adults, the results are better in pediatric population
Period.
for the ACL repairs.
Definitely. So repair is something new thing that is happening. I think we should not. Only the correct indicated case should be done for that.
Yes.
At least you can augment it without removing that ACL. Whatever
And
ACL.
anyway, taking hamstrings and all in pediatrics, is there any the prognosis is worse compared to adults? Hamstrings in the graft taking in pediatric growing children. Any thoughts on that? To
There are no
avoid the
studies
repair
like
is
that. No?
better. Yeah, I also always considered taking hamstring and all in children. What would their prognosis be?
CQT you can take CQT. Then.
Better to go for such grafts. In
There are no
pediatric
much
patients.
studies as
Like,
Dr. Dinesh was telling. The literature is not that great
Yes.
for pediatrics, so you can't have a sure short answer for that.
that's a
There are a couple of questions for Sibin sir. I'll just ask them on YouTube. 1 second. So Mozammil has asked question. How do you prevent the residual laxity that follows after PCL reconstruction?
So that's what I told you. There are a few things to reduce the laxity. One thing, make sure that it's only PCL. There is no other associated collaterals or something there. If it is there, that you have to treat. Secondly, the graft diameter, make sure that there's more than 9.5. So take a adequate graft diameter. Third thing, have a better strong fixation. That's what I told you. You can try a hybrid fixation type because both on hybrid on both the tibia and the femur. Fourthly, try to have the proper rehab. That means you have the proper PCL brace and all that. But whatever you do, the some laxity usually happens in PCL, but that's not clinically significant. You will not get the 100% 10 mm step. Usually they come from grade 3 to grade 1. You can't make it completely, usually just like the opposite side, because there is some capsular injury that we are not treating. There are some missed injuries, maybe there, some capsular, some stretching. So basically, but you want to have a good, strong, the posterior stop should be, there should not be lax stop. The endpoint should be sharp. So these are the things that I think we can do. And some people say that you make a double bundle PCL on the female side that reduces the laxity. I don't have much experience with the double bundle on the female side. But the other things, anything else? Anybody can contribute.
Another question, yeah. Where do you put the screw in femoral tunnel? Anterior to graft? Is it anterior to graft? And is there any incidence of anterior blowout?
No, you don't. That's a good question. So you don't put the same size screw as in the tibia. So in the tibia, if you have 9 graft or 10 graft, you put 11 screw. because there is no chance of blowout. In the on the female side, you put 7 or 8 grafts, just 7 or 8 screw on the anterior side that doesn't blow out. It's just a fixation to stabilize that graft, so to reduce the grubbing of the PCL on the edge. Okay, so it's a 8 mm screw, not a tight screw like that. Okay, so then that reduces the chances. So don't put a large size screw.
Correct. Another last question from Dr. Amit Kumar. In chronic PCL avulsion for Dr. Khayas, in chronic PCL avulsion, up to what time it can be fixed?
Chronic PCL avulsions, there is no actual protocol for that. The literature doesn't say that so much weeks you can fix, you cannot fix. So it is basically actually you have to see the chronicity means the fragment will be displaced and it's very difficult. So more than 2-3 months, I don't think it is a good option to go for a fixation of the fragment. Better to go for augmentation or reconstruction. But there is no hard that studies doesn't have a randomized control study is not there to say so much chronicity you go for reconstruction then the fix like that. Because in government setup we usually get neglected cases, so we always are concerned when to fix or such cases come up.
Beyond 4 to 6 weeks, I think it's difficult to get a proper reduction. You will be getting some reduction,
even 4 to 6,
you won't get a correct anatomical reduction. So always take the consent if in a chronic case for a PCL reconstruction also. So rather than just guaranteeing that you will be able to always fix it. So I think more than 6 weeks, it's definitely, I think it's difficult.
Okay, any other question? Dr. Dinesh? Dr. Dinesh Chidambaram?
Yes, sir. I was about to ask Dr. Kayas, but Sibin sir already asked the same. How long will you wait for acute PCL? And second thing, you was telling about posterior translation. You will be calculating if it is more than 10 mm. Is it every time in acute case, will you do stress views and check it out, or how will you assess?
Stress views we can do, but it is very difficult in our setup. So basically that mushy end, the grade 3, that after 2 weeks, when the joint settles, when the patient comes back, that mushy end, that is my grade 3. Grade 2 is not that mushy, that hardened point. Then it's actually, we can conserve even that grade 3 PCL we have to do. Because when we keep it in 90 degrees, that tibia will be sagged. Such cases, you can see that sag. In such cases, it's grade 3 for me. The stress view is good, but it's very difficult in our setup.
Usually what we have been taught is that distance from the displacement, it is more than 5 mm, better to go for fixation irrespective of the stress use and all.
Yeah, lots of protocols are there.
Yeah.
The 5 mm.
Yeah.
Anyway,
quantifying is only by stress view. We cannot quantify clinically 5 mm, 10 mm. Basically, I rely on the feel.
Yeah, reversal of the slope that indicates it's a grade 2 or grade 3. So to always compare with the opposite side, reversal of the slope, you can't quantify, but that indicates that something more than 2 or 3 is there. Definitely.
Yeah, comparison with the opposite side is also important.
Yeah, that's very important. That's what I was telling. So always under anesthesia also you can always compare.
Yeah, so even under anesthesia. Under anesthesia, opposite side. That is very important.
So, that's very
under anesthesia
important.
Is the final.
One thing you should take from this meeting is that always do a UA, examine under anesthesia, compare with opposite side before the patient is draped. Understand? If your assistant may be draping it, then it's difficult. So compare, check the pulse, all the PCL and posterior compartment cases, compare with the opposite side, how much is the laxity. Then you can, under anesthesia, you can easily grade it. Means how much is the, and how much is the lateral or medial laxity. Under clinics, under anesthesia, in the OPD, it may not be possible to elicit it's a grade 3 or grade 2. But under anesthesia, that gives you a good idea. So which are the ligaments or which are the collaterals gone. Okay.
Okay, then if there are no questions, then I think we will conclude here. Thank you very much, Dr. Steven Surendran, for his technique of PM and PL portal use for the PCL reconstruction. It was very nicely demonstrated and your typical style of presentation with the catchy slides. You made it sound very beautiful. and Dr. Khayas for the double button technique, something innovative, very good to try in the fractures, available fractures with a big fragment. And Dr. Dinesh gave all our presenters. Islam, who joined all the way from Guwahati, and Dr. Dinesh Chidambaram from Coimbatore for moderating this session. On behalf of Indian Arthroscopy Society, I thank you all. And our webmaster Naresh Gaud and my dear colleague Dr. Rajiv Raman. Thank you very much.
Thank you.
Thank you, sir. Thank you.
Happy New Year in advance to all.
Sir.
Happy New Year to all.
Yes,
Yeah,
yes.
Happy New Year.
Happy New Year. Happy New Year. I'll just